Hello, good day to everyone. Welcome everyone to our 21st IACAPAP webinar. I'm delighted to be chairing this session today. So today's webinar is going to be focused on the clinical role of pharmacology in treating psychiatric disorders in children and adolescents. While medications such as stimulants for ADHD and other psychiatric medications can be highly effective and even essential in severe conditions, such as schizophrenia or severe depression, their success depends on one key factor, which is patient adherence and persistence. Unfortunately, poor adherence remains one of the biggest challenges in ensuring effective treatment outcomes. Despite the proven efficacy and tolerability of many medications, they are often not taken as prescribed. So in this session today, we're going to explore the reasons behind non-adherence and non-persistence in young people with ADHD and other psychiatric conditions. And we're going to identify those greater risks, to review methods for assessing adherence and persistence, and we're going to discuss the strategies for improving it. So I am very pleased to introduce my colleague, Dr. Alex Häge, as today's presenter for our webinar. Dr. Häge is a highly respected expert in the field of child and adolescent psychiatry with extensive experience in psychopharmacology and mental health treatment. He is the Deputy Medical Director of the Clinic for Child and Adolescent Psychiatry and Psychotherapy at the Central Institute of Mental Health in Mannheim, Germany. He leads the research group Pediatric Psychopharmacology, as well as the research group ADHD in Childhood and Adolescence. His research focuses on clinical trials, particularly on the efficacy, tolerability, and safety of new pharmacological treatment approaches. He has been involved in different research activities funded by the German Federal Ministry of Education and Research. He has also participated in European Union funded research projects, including the 2020 projects ADUSE of attention deficit hyperactivity disorder, drug use, chronic effects, the PERS, pediatric European risperidone studies, and the STOPS suicidality treatment occurring in pediatrics. Dr. Häge has also contributed to the development of the S3 guidelines on ADHD and conduct disorder, and he's a member of the AGNP Pediatric Psychopharmacology Working Group and the European Network for Hyperkinetic Disorder, UNITHIDIS. Today, Dr. Häge will be sharing valuable insights into the challenges of medication adherence in young people with psychiatric disorders, exploring the cause of non-adherence, and offering strategies for improving therapeutic outcomes. We're excited to have Dr. Häge with us, and I'm sure this will be a very informative and engaging session for all of you. So please note that you can leave the questions along the presentation and that they will be answered during the question and answer session at the end of this meeting during the last 10 or 15 minutes. And please also feel free to raise your hand if it's something that you think needs to be discussed or you want to ask. Please join me in welcoming Dr. Häge.
Thank you very much, Maite. Thank you. I will give you my presentation now. And yeah, let me, in the meantime, say I'm very honored to have the possibility to give this talk today. And I'm also especially very happy to be able to talk about a topic that I think is clinically highly relevant. And I know I have just round about 30 minutes, that's to be honest, not enough to cover all the aspects that are important, but I will give my best to give you a nice overview and some input on what, from my point of view, would be clinically very relevant for our field. Okay, I start with my conflict of interest. As you said, Maite, I'm a child and adolescent psychiatrist, and I also do research, and I have a small research group on pediatric psychopharmacology, and there we did lots of studies, RCTs, also on the efficacy and safety on medication. And that's the reason why I got into contact with many pharmaceutical companies, and this is why they are all listed here. And today I want to talk about psychotropic medication. And we do know that they are important for our field and that there are many different disorders where medication is really helpful. I would say that we should be aware of that our field is basically very large. We treat many, many different disorders. We treat almost all the different disorders that also are treated in adult psychiatry, plus all the psychosomatic disorders, plus the child-specific disorders. So there's a range of disorders we treat, and for many, medication is really important. There are also disorders where medication does not play an important role. For example, if you think of post-traumatic stress disorders, there was much of research going on to find medication that helps, but at the end, we have to say psychotherapeutic interventions are key there, and medication is not so helpful. Or, for example, if you think of, you may be aware of that lots of research going on to find medication to treat the core symptoms of autism. But until now, there's no medication found that really addresses the core symptoms and has an effect on that. So I would say this is also an example where medication is not so important. But on the other hand, there are many disorders where we need patients to take medication. And if you, for example, treat patients with schizophrenia, you will be very well aware of that there are many who urgently need an antipsychotic drug to get better. And you have the frustrating situation that many take medication, get better, and then stop medication and get worse again. And this is really challenging. Or with ADHD, for example, we have really a medication with very high effect sizes, and where we could say we have a good option to treat many patients, but we experience that many maybe started, but then after a while stopped to take it, and even though it was helpful, and this can also be very frustrating sometimes. And of course, we have antidepressive medication that can help with depression, with anxiety, with OCD. But also there, we have many patients who are not really adherent or don't take it sufficiently, and then don't recover from their symptoms in the way we would like to see it. So overall, we have medication plays an important role in our field, but of course, I mean, this is clear. The medication, even if it's effective and safe, it can only work if the patients really take the medication. And that leads us to the issue of non-adherence and the topic of adherence. And I would like to show you some research results and give some clinical recommendations that hopefully are helpful. First of all, if you would like to give a definition overall of what is adherence, you can take a look at what the World Health Organization is saying. They define adherence as the degree to which the behavior of an individual, for example, in terms of taking medication, corresponds with the recommendations of a healthcare provider. And they also say that it refers to the extent to which a patient follows the prescribed treatment regime, including correct timing, dosage, frequency of medication, and so on and so forth. And maybe you are also familiar with the more old term of compliance, which we do not use that often anymore. But basically, if you talk about non-compliance or non-adherence, you always mean the problem that patients are not taking their medication. But in the concept, there's a slight difference because compliance is more based on the idea that you have, like in old times, a relationship between doctor and patient where the doctor says, this is what you have to do and gives instructions. And the patient at the end follows the instructions or he doesn't. Yeah. And if he doesn't, you can consider this patient non-compliant. But nowadays, I think we have moved on and we try to have, to replace that by a more, a relationship between physician and patient that is more cooperative. We want to have this shared decision making. The patient should be involved in the process of making a decision. And then we say if we have come up with a plan together with our patient, and then the patient is not following that, we would rather say he's non-adherent to our plan of treatment. Yeah. There's also, Maite, you mentioned it, there's also the term of persistence, this which is also related to adherence, but I decided in terms of time issues, I will today not so much talk about persistence, but focus on adherence and give some research finding on this topic. When we ask when is a patient adherent and when not, we face the first problem we have in adherent research. That is that there is not an overall accepted definition. If you look at clinical trials, pharmaceutical trials, it is very often said or defined that they say a patient is adherent when he or she takes at least 80% of the medication as prescribed. But there are also other definitions used in other trials. And there's overall also, you can say, two conceptual approaches that are slightly different. The ones who say, we have a definition for adherence and we classify patients in adherence or non-adherence. But there's also the more dynamic approach that you say there's different levels or different levels of adherence, and you may say someone is fully adherent, partial adherent, and so on. So this is another perspective. So the main message for this slide is be aware of that there are different definitions. And of course, if you look at research on adherence, this is a problem because you have different studies, they use different definitions, and it's different to bring that together. Yeah, that's a challenge in the field. And another challenge is that there are different ways of measuring adherence. And you may divide that or distinguish in those you may call objective methods and those you may call subjective methods. So objective would be if you take saliva samples or blood samples, or if you do pill counts, you may say this is more an objective way of measuring it. Whereas on the other side, if you just ask the patient, do you always take your medication or are you adherent, or you ask the parents, or you use a questionnaire, you may say this is more a subjective way of measuring it. And well, as always in life, everything has pros and cons. And if you look at the measurements, you may find some that are very easy. Asking the patients is very easy. There are some who are more costly. If you do take blood samples from every patient, this is probably not feasible to do always. Some are more accurate and objective, some are more subjective. But the thing is, if you look at research and, for example, look at clinical trials that use different ways of assessing it, you will see that they end up with different results. For example, if you want to know how many patients in a group of patients are adherent, and you use different ways of measuring it, you will end up with different rates of adherence. And this is an example of a study most of you will be very familiar with, the MTA study in children, ADHD, many children treated with methylphenidate in this study. And they also looked at adherence, and they measured it in two different ways. Because on the one hand, they took saliva samples at different time points. And on the other way, they just asked the parents, is your child adherent and does he or she take the medication? And if you look at the results, you see that on the one hand, with the saliva samples, they found that around about 25% of the participants were non-adherent. And on the other side, if you look at the parents' report, it was much better because almost 90% of the parents gave the feedback that their child was adherent with the treatment. So there's a significant difference. And so you always have to be aware of the fact, depending on which way of assessing you choose, you can end up with very different results. So these are the two challenges: no clear definition and many ways of assessing it. However, overall, I would say there is no doubt that non-adherence in the field of child and adolescent psychiatry is relatively high. And there are different systematic reviews and also meta-analysis that looked at it. I don't have the time to present all of that, but at least some examples. Our group did a systematic review on non-adherence to psychotropic medication among adolescents with mental health disorders. And what we found was non-adherence rates that ranged between 6% and 62%, with a median of 33%. So a large amount of patients who are not adherent. And this is another review that was on medication adherence among children and adolescents with what the others call severe mental illnesses. And they found that around about 34% of the participants were in these studies were non-adherent. And I would also like to mention the review by Maite and colleagues where we looked on ADHD medication adherence, also with a little bit of a frustrating result, because if you looked at those studies who used the same definition of adherence, you see that after 1 year of follow-up, only round about 23% of patients really show good adherence. So also here, a large number and a large rate of patients who maybe start taking it, but don't adhere to what was planned at the beginning. And so this is overall a big issue. And there are also reviews on other disorder and medication adherence on other affective disorders and schizophrenia and so on and so forth. But in every disorder, this is a big issue and a problem. So I believe that this statement here is very right, that if we would find a way to really significantly improve medication adherence in our field, it may have a greater influence on the health of our population than in discovering new treatments. And I truly think it's really important that we put more efforts in finding ways of improving adherence of our patients. Now, the clinical guidelines are, I would say, partially aware of that problem. There are many guidelines in our field that address adherence and give recommendations on adherence. Just one example, because this is a group where I'm involved in the process of guidelines as well. This is our German guidelines on ADHD, and there is in the current version a short chapter on medication adherence, but in the new upcoming updated version of the guidelines, there will be an even more comprehensive chapter on adherence, which I think is very nice because this is an important part and you should put a focus on that as well. And if you read what they are saying is, of course, first of all, be aware of that poor adherence in the treatment of ADHD is common. Yeah. It should be regularly monitored. And if there are signs of poor adherence, try to find out what are the underlying causes for it. And this is the first big challenge, so to say, because the reasons for non-adherence can be very different. There are different reasons why patients do not take their medication. And I've just listed here some of them, some things that should be considered. And this is, of course, on the one hand, side effects. All our psychotropic medication can cause side effects. And of course, side effects can lead to the problem that patients stop taking the medication without telling you as a physician, and sometimes also without coming back to appointments. And of course, there are many different side effects we have to deal with, but I would like to just mention one which I think is very important, especially for those of you who prescribe antipsychotics and antidepressive medication, and that is sexual dysfunction. Because very often patients do not feel comfortable with talking about this subject. And unfortunately, also many physicians do not feel comfortable with talking about that subject with your patients. And this can easily lead to the problem that patients suffer from such side effects, don't tell you, and don't come back or don't take the medication, even though there would be good options in finding another compound or finding solutions for that. So please, if you prescribe antipsychotics and antidepressive medication, think of that side effect and talk with your patients about it. If a medication is not effective or the patient has the feeling it's not working, this is also a risk factor for non-adherence. If patients have the feeling they don't need treatment, I think this is also very often the case in our field, that we have children or adolescents that don't come to us because they think I have a problem, I need help, but there's often lots of pressure. Parents put pressure on the children, or teachers, school, they want the children to get help. But if the child or the adolescents does not see it that way by him or herself, then it's also more likely that they will be not adherent with a treatment. There's research that's showing that the more complex the dosing regime is, the more likely that the patient is not adherent. So having to take the medication more than one time a day, taking different medication, the more complicated it is, the more likely that the patient is not adherent. Stigma is a big issue. Yeah, if the patient, for example, has to take the medication at school, others see that he or she has to take a pill. What is that? What you are taking? What's the reason? I mean, reactions from others can be very, very hard. I think in every part of this world, people with mental disorders experience stigma, and that can also lead to non-adherence. And also, and this is what I mean with loss of sense of self, sometimes children or adolescents who take a medication experience that the medication has a strong effect. For example, suddenly they are much more calm, or they are much more focused, or not anxious anymore. So they experience that something is very, very different, and they may have the feeling that, and they say, this is not myself anymore. This is not me. I'm different. Suddenly I'm very different. And that may be a feeling that's uncomfortable and may lead to non-adherence, or that they stop to use medication. And the last thing I think is very important, that and especially with adolescents, that the subjective attitudes they have towards medication and towards the construct of the disorder is key. What they think about medication overall, about psychotropic medication overall, and about our constructs of mental diseases, this is very important for adherence. Okay, this again is a result from the review I mentioned on adherence in ADHD in children and adolescents. And here you see some factors that were identified in the literature that are related or associated with better adherence, the green ones, and those factors that are often related to reduced adherence or worse adherence, the red ones. And you see again, for example, younger age at treatment onset is often associated with better adherence. You can also say, in general, children are often more adherence than adolescents. If you use long-acting formulations, again, this is helpful. Patients are more likely to take the medication if it's easy, just once a day, and so on. But on the other hand, there are some factors that are more associated with less adherence. For example, poor family support. For example, lower IQ and lower socioeconomic status. There's some literature that show that there's a association. Multiple dosing. Of course, if medication is not effective or side effects occur. Negative opinion about medication, stigma, and a less trustful physician-patient relationship. Those are all aspects that are more like, have to be seen like predictors for non-adherence. This is a study we did with where we did interviews, very comprehensive interviews with adolescents with mental diseases who were prescribed medication. And that was, interestingly, in this study, we did not found a clear association between the efficacy of medication and adherence, and also not between side effects and adherence. That was not such a that was not significantly with associated factor, but we found that how the patients saw their relationship to the physician, whether it was trustful or not so trustful, that played an important role. If they felt support from the family, that played important role, that was associated with better adherence. And also when they had an overall negative opinion on psychotropic medication, that was a very strong factor associated with less adherence at the end. So overall, you have to be aware of, first of all, there are many different reasons for non-adherence. There are different predictors for non-adherence. And it was not possible in research to find or to identify any subgroup where you could say that's not an issue with non-adherence. So because one may think if the patients are very smart, high IQ, very educated families, they will understand that it's necessary to follow the instructions and be adherent. But this is not the case. Non-adherence has to be considered with all of your patients and all the different groups of patients you treat. And as I said, especially with adolescents, it is very important to have a look at what attitudes and opinions they have. What do they think about medication? What do they think of our constructs of disorders? So, I mean, the important question for a clinician is what can you do to improve medication adherence? And there, first of all, again, it's important to be aware of different causes for non-adherence. Also mean that there is not one solution that fits all. There's not like one program or thing you have to do to improve adherence, but you have to find individualized solutions for your single patients and for each problem. And just one or two examples in this context. If you have a patient who wants to take the medication, who believes it can be helpful, who wants to try it out, but is forgetting it all the time and has problems with organizing his life, is forgetful and so on. So having a problem that you may call unintentional non-adherence, it may be helpful to use reminder tools, for example, certain apps that remind him or her of taking the medication. But on the other hand, if you have a patient who has doubts about the medication, who has concerns, and maybe it's not so much talking about it, but maybe thinks, oh, is that really helpful for me? Or am I really ill? Do I need that? Should I take that? If you have a patient like this, it will probably not be very beneficial to give him an app or use reminder functions. But then it may be much more helpful to spend more time on psychoeducation. And sometimes it is helpful to more use or have a stronger focus on a biological model of understanding what's the mechanisms of the disease and in how far can medication be helpful. We have more and more apps, and there are also more and more apps that are used in the field of mental health, and there are also more and more apps that use try to also improve compliance and adherence in patients, and there are also many RCTs that showed that overall this is effective. If you use apps, reminder functions, and so on, you overall have a better outcome in medication adherence compared to control groups. There are different trials that showed that also in ADHD, but also in other mental disorders. Yeah. But what I believe is also very important, and this is why I put that at the end of my talk, is to work on a good physician-patient relationship, because I truly believe, I mean, there's some research showing it, but I would add that I truly believe also clinical experience shows that the quality of the physician-patient relationship really is essential for approving medication adherence. So having an open, trusting communication about patients' concerns, about their fears, about their wishes and expectations. I think this is really crucial for, at the end, having good adherence. And I mean, I believe that every one of you and every psychiatrist and psychotherapist is very aware of that. But my concern is that politicians who also are responsible for the settings in our in mental health and our healthcare system, they are often not so much aware of that. Yeah, they think if you have a medication that is effective and safe, you need a doctor to prescribe it and briefly monitor it, and then you have a good outcome. But it's not that easy. You nevertheless need to spend lots of time with your patient. You have to do a good psychoeducation. You have to try to address all the concerns, the problems with stigma, their reservations. And I truly think it's key, even if you like just prescribe medication, to have sufficient time to talk about all these things with your patient. And it's really key to have this time for this shared decision-making process. And I personally think that it's helpful to not, or to avoid pushing your own opinions on recommendation too forcefully. Yeah, like, not, I know this is the most effective, you have to take that, that's the best, but more try to find a way together and sometimes make a compromise. And yeah, I think at the end the outcome will be better if you go that way. So my take-home message is, first of all, be aware of that non-adherence, and in particular medication non-adherence, is very common in our field for all the different disorders we treat, and you should always consider it. There's no subgroup where you can exclude that medication adherence is a problem. You always have to be aware of it. And there can be many reasons for non-adherence, and there are many different predictors. That is also why there's no overall evaluated intervention you can recommend to use if there are adherence problems. But there are certain aspects, key aspects you should consider. First of all, it is worth to spend more time into a comprehensive psychoeducation. It is worth to spend time to build a good and strong therapeutic alliance with your patient, even if you just prescribe medication. Try to identify and address the individual needs and the preferences of your patient. Be aware of that family support and support from others is associated with better adherence. Have an open discussion, try to assess adherence frequently, and maybe be not so strict. Sometimes it's helpful, but I think with most of the patients, it can be wiser to be more, forgiving if they are not perfectly adherent. and don't do everything you recommend. And last but not least, the easier the treatment regime is, the more likely the patient is adherent to it. Okay, and this is my last slide. I want to thank you for your attention, and I also want to, make you aware of that we have the next IACAPAP World Congress in Germany in 2026. It's the 1st till the 4th of July. Please save the date. I know there are, well, it's always also a problem sometimes of time, and traveling costs money and you need funding for it and so on and so forth. And there are many conferences, but I truly believe for 2026, this is the conference to be, and Hamburg is the place to be, and I guarantee you will not regret it. So this is my recommendation, and it would be nice if you, would be compliant with that. Thank you very much for your attention, and I'm very curious about your comments and questions now. Thank you.
Thank you very much, Alex. It's been really informative, I think very comprehensive as well. It's such an interesting topic, and it's not very well researched, I need to say, because both of us have been involved in this review, and we found that there aren't many kind of scientific papers on such an interesting topic. Okay, so I'm going to now
should I stop sharing my screen, by the way?
Yes, I think so,
okay.
please. Yeah. And now, okay, hold on. I think I can share my own screen now. Right. Now it's time for questions and answers. I have some questions and answers already. My first question, Alex, because I think you tapped on it, but I think it's very important, as you said, non-adherence is complex, and there's no one solution type of way of dealing with it. You also mentioned the importance of psychoeducation, and psychoeducation, I think, is very crucial for tackling different factors, such as stigma, or such as beliefs around medication or around the illness. How, or even the loss of sense of themselves or self that the patient might have. So what would you say, or how can you kind of recommend psychoeducation? Is there any way of trying to improve psychoeducation in mental health services, do you think, Alex?
Yeah. Maybe 2 ideas or 2 comments to that. First of all, I think if you prescribe medication and you want to have a patient who trusts, and that could be a benefit for him, you have to, as I said, you have to include a biological model. You have to explain what the effects of the medication are, what research knows about the disorder from a more biological perspective. I think this is helpful to gain a deeper understanding of why does it make sense for me to take this pill to help me with problems they may not so obviously be related to a biological mechanism or so. Yeah, I think this is key. And very often psychoeducation is something you do at the very beginning. It's like a checklist, psychoeducation, and then you start with other treatments. But I think it's helpful to see it as a process. You do not just do at the very beginning, but do it again and again, and yeah, bring up this topic. And also when, yeah, it's a time issue, of course, also, but I think that would be truly helpful. Yeah.
Yeah, absolutely. And then I guess psychoeducation, not just with the young people, but also with the families, right? To get them involved and to get them, yeah. So not just, so it is, as you say, it should be an ongoing process, because the situation, as the kids and young people evolve, the situation is changing, right? Isn't it?
Yeah,
So
yeah. Yeah,
absolutely.
and maybe one additional comment. I think you're perfectly right. If you talk with the parents and the child, but for example, there's there's a tough grandmother, for example, who says, I don't want my grandchild to take medication. That's not good. You should talk to her as well. Yeah, just to give one example. There are sometimes other people who have a strong influence, and yeah,
Yeah,
try to talk to them
absolutely.
as well. Mm.
So I'm going to continue with the questions because we have quite a few. So there's one question. It says, like in the case of schizophrenia in adults, and this is almost kind of answered by what we were discussing. The shared decision making is important to get good adherence. And in the case of children and adolescents, do you think like is there a similar thing to maintain adherence? And so I think more or less we've answered that, right? The importance of having a shared decision making with them. Then the second question would be, in addition, do you know unique treatment factors that are related to children and adolescents adherence? I'm imagining only, not to adults, but more to children and adolescents, and how can improve the adherence in a concrete way.
Mm, I didn't get the beginning of that question.
Yeah,
What
I think what that means is that if there are any specific factors that are more related to children and adolescents adherence instead of adults adherence, such as
yeah.
I would think of one can be like a family. I mean, if the parents are not, because parents are giving the medication to them, if parents are not involved, then the adherence in children and adolescents is going to be, especially in the little ones. And then adolescents might be more like I don't know, the idea of like how adolescents think about medications, and then that they need to start taking responsibility of their own medication, something like that is different
Yeah.
from adults in a way.
Yeah, yeah. I mean, the challenging thing is always that we have to, typically, there are three persons we have to find agreement with. Yeah, it's the parents plus the child. And especially in adolescence, it's very often that this is a period in your life where you like to be a rebel. You don't want to do what the adult people or parents tell you. You like to say no, and this is, I think, also why this is the most challenging period in life for adherence. And also the literature is also showing it. Non-adherence is even much more pronounced in adults compared in adolescents compared to children and compared to adults. Yeah, this is challenging.
Another comment reflecting on your presentation is great, Alex, and asking if there is a single tool that you would recommend for monitoring adherence. If there was a single tool, what would that be? Sorry.
Okay, yeah. Again, unfortunately, I don't have an overall answer. I would say, first of all, what you should always do is bring that into the discussion. Talk to the patient about it. Do you take it? Do you have any concerns? Is there anything you feel uncomfortable with that makes you think you rather want to stop it? Or did you even stop it? You can be honest. I don't judge you, and like that. Then have a look at your prescriptions. Yeah, check if that makes sense. How often do families or patients ask for a new prescription, and does that fit to the number of tablets the patient should take? Yeah. And then there are, of course, also cases where it may make sense to take plasma levels. If you think of schizophrenia, for example, if there's a patient who's not getting better, yeah, generally check. There are many reasons for taking plasma levels in this situation, but also it's helpful to check whether they take the medication or not. Yeah.
So one more question is, when you mentioned about forceful decisions, Alex, in the slides, will there be a check on this by any guideline, or is there any checklist on that you're aware of, like about forceful decisions, I guess?
Not right away, no. Are you aware of any?
No.
Oh, no.
No, I guess, I don't know. My forceful decisions would be something is about your feeling and your relationship with the patient. So I think, as you mentioned, Alice, it has to be like a relationship where the patient is feeling free to express and to work with you, instead of you making the patient accept your decisions. It's about it's a shared decision process, and where the patient is asked about their opinions, and then and therefore I think that is reducing the forceful decisions, because you're not forcing anyone to take a treatment. And I think, I don't know, I think in my experience it's about at all times and knowing or feeling that you're not forcing this particular patient, and also kind of stating, like in the session, that you're not going to force that. If they want to if they don't want to take treatment, it's absolutely fine, but it's about for them to communicate the reasons why they don't want to take the treatment, because as you said, it might be some kind of side effect that can be overcome, and then by using another drug, or it can be like a false idea about and it's when you need to kind of have this dialogue with the patient. I'm not aware of any forceful decisions now in any guideline either. Then another question is, have you sometimes dealt with non-adherence in the child because of opposing views about the medication by each parent, especially in parents who are separated, obviously,
Yeah, I would say very often, and not only if they are separated or very different opinions. It helps, it doesn't help. I'm against it, I'm pro, and But I mean, yeah, I would say this is a normal challenge of our field in many ways. Yeah.
You have to deal with it, isn't it? And there
yeah.
might be a parent who think, I don't know, medication is not useful, or medication can have side effects in the long term. And I think it's about breaking barriers as well. And again, about psychoeducation and trying to present evidence, and for them to know about evidence, because sometimes this is most of the times based on a false belief, that, I don't know, that you child can get hooked or can get depending on the medication. So, and sometimes it's about both parents to understand what the scientific evidence is saying.
Yeah, sometimes parents think I would get money from the pharmaceutical industry if I prescribe medication or things like that. Or it's weird. Yeah.
Then another question is says medication adherence for the child and adolescents in one particular country is heavily dependent on the caregiver, and they list like three things. One is parents have to afford the medications, to make it available. Second, parents have to believe in the medication. And then school, those can be missed due to stigma, as you have highlighted. So what is your experience in relation to these three?
What was the second again? Sorry.
So the second is parents have to believe in the medication. So again, parents understanding the role of medication. Parents have to afford the medication, have to believe and understand the medication, and then the school issue. Right?
I think the beliefs are really key. The expectations, because we also have, in addition to what a drug does, we have placebo and nocebo effects, like add-on effects. So if you have patients or parents that say, I'm very afraid of side effects and I've read so much, and they have these expectations that their child will suffer from side effects, and then they come back and have all these side effects they mentioned before. This is sometimes you get at the beginning a feeling of whether the parents will tell you later that what they observed. So the expectations play a very, very big role. And with school, my experience is that well, sometimes it's difficult to if they should, for example, take medication in school, it's sometimes challenging to have an agreement with the teachers about it. And you have to be aware of that there's also stigmatization. If teachers are aware of that there is a mental disease that can have an impact on their judgment, and this is not so easy. So sometimes it makes sense to talk with them and be open if the child and the family wants that. Sometimes it's even better not to. Yeah, it depends, I would say.
Thank you. And we're going to go to the last one, okay, which is considering that most psychiatric conditions are for life, and the management usually involves long-term, if not lifelong therapy. Do you have any strategies to give to the patients hope?
Strategies to give hope. This is a tough question, but yeah, and it really depends on what disorder we are talking about. I mean, there are many disorders we have to deal with that should not be seen in only a very negative, from a very, very negative perspective. If you think of ADHD, for example, it also makes sense to say it seems to be that ADHD is also related with positive aspects like creativity or spontaneousness and so on. You can try to bring that up, and even if you have, and I do not talk a lot about statistics on how big the chance is of having a relapse and so on, but because individually this is very different, and too much focusing on the bad things in life is never a good strategy. Yeah. Sometimes it's good to get distracted from what is not so nice. Yeah.
Thank you, Alex. I think it's been, as I said, very informative, and I think it gives us food for thought to all of us. Then I'm going to now I'm going to thank participants, and I'm going to so thank you for joining us in this webinar today. As you can see, the certificate will be, you have, for the certificate, you have to complete the survey, which is at the end of a webinar, okay? And then I would like to invite you to the 22nd IACAPAP Lunch and Learn webinar, which will take place in March this year. So the topic will be the role of parents in the management of neuropsychiatric disorders in children. And I think it's very much almost overlapping with what we are discussing today. So I'm sure there will be things that are going to collide or rediscuss in the next webinar. It'll be presented by Dr. Mashudat Bello Mojid. They're also just like a reminder of our membership. So you are welcome to join our association, the IACAPAP. It has many benefits, and yeah, and I'm sure you're going to take advantage of all the possibilities that IACAPAP is offering. Also, like to announce the MOOC 2025, you can start enrolling from the 13th of January to April. So still plenty of time, okay? So again, very useful tool for many participants, and it's free. So. And finally, we are looking for articles to be published in our bulletin. So also feel free to contact us if you think there's something that can be interesting to be shared and to be seen by different professionals in different parts of the world, because I think it's very important that we share our views on different topics, and the bulletin is a good way of doing it. And yeah, finally, just save the date, as Alex has said, it's going to be an important meeting, and different topics are going to be discussed. So I think it's going to be very fruitful. So yeah, okay. So I think that's it. Again, thank you so much to all the participants. I hope you have enjoyed and you have had a useful session today, and see you on the 22nd webinar. See you all. Thank you, Alex, once again.
Thank you for having me.
Yeah, we hope maybe we will have you back to discuss the remaining things, that because obviously it's been like a 30-minute talk, so many things are still kind of couldn't be discussed, but I think you've done a wrap up of the situation, how it is now. So but maybe in the future we will have you again. Thank you so much for your time.
Yeah, thank you.
Thank you. Thank you all.